research they're doing and how they're changing the world. And that's always very exciting. It's always nice to hear. But we felt that really with these meetings we should be trying to do a little bit more than that. We should be trying to stimulate people, educate them, be a little bit more topical, encourage discussion. And certainly when we sat down and thought, what is there that really could generate a fairly decent discussion, then the issue of birth, intervention in birth, mode of birth, carers for birth, etc. is very important. Some of you may know that a number of us speaking this evening are very passionate about these areas and very closely involved. And I'm sure many people come with really quite strong opinions on this topic, and I'm sure that's why we've got quite a lot of people who come tonight. This is deliberately intended to be as much a piece of entertainment as anything else. So we've deliberately chosen two people who I know are very good speakers, who I know are very entertaining, who I know aren't going to be laying into each other over drinks at the end and trying to tear each other's heads off. And that meant that I had to discount about 3 or 4 people who I thought might be quite good initially, because then we thought about the potential for fights and just thought, that's never going to work. But I think the important thing is that we are all in the room having a chat about this. We all come from different perspectives, and I would just ask people, as I'm sure they would anyway, but please respect those opinions that might be quite different to yours. And by all means, we would like lots of spirited discussion. I'd be extremely disappointed if you just heard 2 people speak and said thanks very much and then just had a glass of wine. That would actually be quite good if you had a glass of wine anyway, but it would be a shame if there wasn't some discussion. So we're hoping that we'll be able to open this out, have a fair amount of discussion at the end. So none of you have come to hear me talk, so I'm going to wrap up and introduce our speakers. The first of our speakers is Dr. Peter Bland. Probably the cliche about Peter Bland is that I'd say by name but anything but in nature, which must have been said many times about him. Well, Peter is a very entertaining obstetrician who I've had the pleasure of spending about 6 years sitting on a committee with, and he's, for about 6 years, made exceptionally boring Grangscog committee meetings really quite entertaining and fun, and has known exactly when to poke the pin into the balloon of those people who need it. Peter's a senior experienced obstetrician, 31 years in the discipline, which is a fair time in the public and private setting. He's worked both in rural and metropolitan areas, particularly spent a lot of time in the rural area, and is very well informed about what happens within the discipline of obstetrics, particularly within this state. I know Peter likes to share his opinions, so please join me in welcoming Peter.
Thanks, ladies and gentlemen. Thank you for the opportunity. Let me just see if we can play the computer a bit. What can you do? You're supposed to do this. I can't do it off this screen. We can just watch this all day. I escaped. Now, thanks. I'll get that bit. Where are you? This slideshow, sorry. Thanks. Thank you for the introduction. That was very generous of you. It's really good to have this midwifery doctor collaborative thing going again here tonight. It's fortunate that if we're on the opposite sides of the collaborative deal. I know Sally claims to over 30 years experience of this in her bio. I just point out that I claim 31. I actually added it up. I thought it was worth mentioning. Not that this is a competition, I just want to point out that. The question tonight's in 2 parts. We're talking about is patient-requested caesarean section a reasonable choice, and that's probably what most people are focusing on, but is it the right option for the Duchess? Not knowing the Duchess that well, and having a little bit of experience with the other stuff, I thought I'd try and discuss mainly the issues regarding elective caesarean section with references to the applicability to Kate where necessary. I'm going to call her Kate because I feel as if I've got to know her during this process. Now, I'm an old patronising male obstetrician, close to it, and I notice I've omitted the old misogynistic word there, which is, you may think differently by the end of the evening, but we'll try and leave it there for the time being. I'm the father of 2, and much of my counselling patients, God forbid, is similar to how I've brought up my children, which is probably the bad thing, but that's going to become clear as we go through some of the stuff tonight. A friend of mine recently described a game called Cranium, if you've heard of it, but it's one of these family games where we sit around and have a chat. And what you have to do is that you're given a card to read through and then try to describe the word on the card using a certain number of words that are not allowed to be used and some that are. And the word on the card that was trying to come up with was hidden, and the clue given to the family was you can't get drugs unless you have one of these. And the 14-year-old son said, "Oh, Gila." The wife and my friend said, I think it's a prescription. What I'm trying to get across here is that perspective is something which is important in this case, because it's all about says who, or what are we trying to say in this stuff. So, who says caesarean section by choice is appropriate or not? As the old joke points out, we're all about opinions. Opinions are like arseholes, everybody's got one. And I think that this is a list of people who seem to have them. Some people are informed, some are ill-informed, uninformed. They think they're informed, I think we all know them, and some don't want to be informed. That's another important group we'll talk about. Some have the authority to influence others, whether appropriately or not, and that's perhaps where a lot of us come into our journey. Actually, WHO, as in WHO, is very clear on caesarean sections and reckons that worldwide there should only be a 15% caesarean section rate. If they go to places, and therefore obviously 85% are going to have these babies vaginally, if they go to places like where Kate lives, in that's called the developed country, a bit like ours we hope, it's 90.5%. In fact, 90.5% should be having normal deliveries, only 9.5% should have a caesarean section. We're a bit ahead of that, so we need to talk about how to improve that. The medical literature, on the other hand, is not quite so emphatic or numerical in its condemnation of this concept of elective caesarean section. In the United States in 2013, a paper was published to suggest that the elective caesarean section the elective caesarean delivery on maternal request, or CDMR. You notice how we've got an acronym. That's a real worry because it means it's got validity in medicine. But they would come numbering 3% of deliveries were by elective choice by the mother, which is not quite the overwhelming numbers that we perhaps put in some of our journal articles and certainly some of our lay press. Now, given Will's mum is the head of the church, Will's grandmother, I should say, always got that wrong, she's not with us anymore. Given Will's grandmother is the head of the Church of England, I figure we should go to the ultimate authority to work out from the Bible what the answer to this question should be. Now, Jesus was a great advocate of birth, I think we all know. He was such an advocate that he actually got his followers to do it twice. He felt born again was the way to go. And his involvement with the assisted reproductive technology, another area of our specialty, is legendary. It was, of course, the first example of artificial insemination by donor. But that's another area to look at, which we won't talk on tonight. He was a big supporter of the abdominal delivery. He actually said, "Render unto Caesar that which is Caesar's, and render unto God that which is God's." This is, of course, the origin of the delusions of grandeur we see in some of the medical profession. If we look at Kate, and that's certainly something I think we'd all like to do, in an appropriate way, there's clearly a link with her royal status and this Caesar thing. The Roman equivalent was, of course, Caesar, royal was the way it went. And it seems sensible that these powerful people should link via a mode of delivery. It just seems the right thing, since it was named after one of their own. Jesus also said famously, "Suffer little children to come unto me." And the clue's subtle and needs a bit of teasing out, obviously, but the mention of suffering clearly excludes, and it must refer to abdominal, it must exclude the wonderful joys of natural childbirth. So I think that's another indication that Jesus was pushing for the Caesar. The other biblical lesson is the inability to serve God and mammon. You can't serve two masters, and there's a need for the clinician to decide between the individual patient, as the person we deal with, and the greater good of the community, and that's one of the factors that does come into this discussion. This leads us to other certain learned bodies, and we should look at some of the other evidence. Our topical girl is British, obviously, and given its state of origin tonight, the NICE guidelines would be an obvious place to go with the ARCOG green top guidelines, but I've decided, because I'm a bit of a colonial, that we'll go for the local authority and see what they sort of think about this stuff. New South Wales health policy, it has numbers, states that maternal request on its own is not an indication of elective caesarean section, and specific reason for request must be explored, discussed and recorded. This is along the lines of what I used to say to my children: "You're not doing it because I say so, I'm a parent." Makes it pretty easy. It illustrates pretty poor parenting techniques, because it then actually points out that you're not going to do it without any discussion, but then suggests that we should have some discussion by exploring, discussing and recording. This opens the door to compromises and makes it fairly difficult then to make final decisions. The concern we have here is that the policy, is this a policy, is it a guideline, or is it a commandment? Going back to our biblical reference. Having this inconsistency and giving the leeway for discussion creates a lot of problems in this stuff, And our surrogate parent in this situation has confused us by focusing on what we're trying to develop here as the final decision as to whether to do the Caesar or not. This basically doesn't tell us one way or the other. What it also doesn't point out is that what if there isn't a good reason to be explored, discussed and recorded? So if you say there is no reason, does that mean you can do the Caesar or you can't do the Caesar? And so as a policy, it doesn't really give us much of a guideline or a direction of where to go. We also have to look at a thing called informed consent. New South Wales Health Policy, another one of these great documents, points out that patients must be provided with sufficient information about the condition, investigation options, treatment options, benefits, possible adverse effects or complications. But it also, in the same document, says that practitioners should carefully consider whether knowing about a risk is likely to influence a patient's decision. I don't know about you guys, but I find that quite challenging. That's a thing called bias or but that's in the document, so we'll follow the document. This encourages a thing called directed counselling, which we certainly tell our medical students and obviously midwifery students this is not the way to go. It's a real problem if we look at the history of some of the litigation that's happening in our country with the Rogers and Whittaker's case, which was a case of sympathetic ophthalmia, where a person had an operation on an eye and there was a 1 in 14,000 chance that the other eye might go blind. This wasn't mentioned to the patient, who then sued, and we were told that a risk of 1 in 14,000, if it was significant, should be told to the patient. Puts you in a bit of a trouble if you're going to say that last year in New South Wales 5.4% of women had a high-grade perineal tear. I don't know that we tell our patients that when letting them go for their vaginal deliveries or vaginal births, to use correct nomenclature. So it's a bit shady as to we look at the evidence what to do. We do live in an era of choice. It's the generation of want and not need, and we require much more thoughtful strategies than these sort of documentations. So whose choice are we addressing? Are we looking at the woman's choice? Are we looking at the baby's choice, the partner's choice, the obstetrician's choice, the midwife's choice, or the pelvic floor specialist's choice? Alec did mention he was going to get Peter Dietz, who's a world-famous pelvic floor man. Unfortunately, he's not here because he's not as much fun to be with as I am. Don't tell him I said that. He's German, he has no sense of humour. So are we in the business of selling people what they want, or should we be providing a health service for what we perceive they need? What does the evidence actually tell us? It's a bit of a problem. In times of trouble, modern medicine looks for the answer in the back of the book. We go to the literature and to find us the answer. And we're not disappointed in the quantity in terms of that, what we should have, but the quality of the evidence actually falls into disrepute. Appropriately, much of the evidence that I was able to find, given the heritage of our Duchess, it comes from England and looks at really important issues, and they've asked big questions, such as an obstetrician in the UK, would you perform a non-medical caesarean section? Or does this decision vary with where you work or when you work? Would you recommend a non-medical elective caesarean section to a friend? As an obstetrician in the UK, what would be your personal mode of delivery? Predictably, all the male obstetricians opted for abdominal deliveries because they didn't have vaginas. Looking at the parenting text, it's the concept if all the kids at school want to stick their head in a bucket, does that mean you would too? These are fairly inane articles, but they pepper our literature, and it's a real problem trying to sift through and find some quality stuff. The authors are a fairly select group who seem to be more interested in having their name in the press than actually producing some decent or helpful literature. Sometimes they do work with a cloak of science, and a colleague of both Alec and myself called Nick Fisk, who's quite a famous obstetrician, I had the pleasure or otherwise of being in the same year as Nick at university, so he's sort of a mate. Nick doesn't have any friends. He provided a really good article which tells us that the salivary cortisol levels, which are an indicators of stress, are lower in elective caesarean delivered babies. So they're probably good kisses or something, but I'm not sure that it's really going to make a big difference. So the problem with the evidence is it gives us lots of numbers and lots of generalisations, but it doesn't really apply to the individuals we're trying to deal with, and we've got a very special individual tonight that we're thinking about. That's special in a good way, not the retarded sense. There's a large element of disbelief and cynicism regarding the providers of this evidence, and ultimately we're influenced probably more by perception than fact, by friends more than professionals, and especially when we feel the facts have been manipulated by people. When counselling people about caesarean section, there's a bit of science as we should go through. We have to decide who we're going to listen to, and that's the question I recently learned in preparation for this. I don't usually read journal articles, I promise, but in a recent JAMA article addressing the issue, a woman actually stated, I didn't want for her, referring to her doctor, to be hesitant and tell me, no, you don't want that, referring to a caesarean section, and try to talk me out of it. The child parenting gem is that she didn't trust the doctor. And we're obliged, therefore, are we obliged, and it's interesting from the New South Wales health literature stuff, are we obliged to provide information for if a woman chooses to waive the option of having information given to her? It's a sort of reversal of the right to remain silent concept. We should actually run through some of the pros and cons, and if under the section, which is what the parents call I want what's good for you, these are the advantages of having a caesarean section electively. It's predictable, and that means we can time it for the convenience of the woman and the doctor, which is very important. It's a lifestyle improver, therefore. It gives you time off for support people to arrive and come and help you out, which can be significant in cost savings in terms of employment and travel fares if you happen to use cheap airfares. In Kate's case, this is particularly important for the paparazzi because it needs to fit in with other royal commitments. And for students of politics and history, it'll be much easier to remember if we can pick a date that's going to be easy to remember for the future King or Queen of England. That'll be helpful in the history books. It is recognised certainly that vaginal birth is safer than an operative one, whether it be a vaginal or abdominal, and it's also recognised within the subgroup of caesarean sections, a cold elective procedure is less morbid than an emergency one. And the only delivery option which can be prospectively allocated to a woman would be the cold elective caesarean section. It'll decrease, but not avoid pelvic trauma. 1 billion papers, many by paediatrics, most by paediatrics, have addressed this question. And on a personal note, they're bored with kids. When talking to women, I resort to brevity, not like tonight. When it comes to damaging soft tissue of a woman's pelvis, pregnancy is bad for you, labour is worse for you, and delivery is the worst for you. Can any of these be avoided if you want to have a baby? Options are self-evident at various points along that journey. You can adopt, you can head for surrogacy, you can do caesarean section, and let's face it, the idea of procreating with someone else outside the royal marriage would be a precedent we'd like to avoid before. Could it be cheaper? Well, if we opted for all the births by caesarean section and removed the option of vaginal birth completely, we could do away with labour wars. And we could provide a 9-to-5 service, operative service, and that's how we deliver all our babies. And the costing of this would be quite an interesting option, although I'm conscious that Kate is fairly well connected financially and her personal costs won't be much of a problem. RANZCOG specifies the medical advantages and protections for the baby attached to the abdominal option. That means that RANZCOG reckons that the baby can avoid certain things. Given that there's a 1.4 per 1,000 chance of a baby dying after 39 weeks, if you chop them all out at 39 weeks, then you avoid that risk. Given that some cerebral palsy is caused by the birth event, if you don't have a birth event through the vagina, you avoid that small risk. They're numbers which can be important to individuals, but on a society basis, they're probably not that significant. So it sounds so good to do this. Are there any counterarguments? And there happen to be a few, so I'll get through. First of all, caesarean section is not natural. Appendicitis, Down syndrome, fungal web spider bites, and tsunamis, they're natural. We love those things. Okay, so bring on vaginal birth. It costs more, or does it? We accept that while a normal spontaneous birth is the cheapest option, if the uncomplicated birth becomes complicated, the costs go up highly and higher than the planned elective caesarean section. It's not woman-centred, or is it if she's the one who wants it? It has a ream of complications, bleeding, thromboembolic infection, anaesthetic complications, trauma to other organs. And they're much more commonly associated with caesarean section than with vaginal birth. But if the caesarean section is an emergency one, where the vaginal birth's gone awry, then those become even more common than with the elective caesarean section. There are long-term placental issues, and we have had a spate of accretors and percretors at this institution and also over at North Shore. And the more Caesars you have, the more likely you are to end up with a placental problem. The problem is that not that many people in the Western world are having that many babies. They tend to quit after a couple, and what really is important to us is how many is Kate planning on having. It's associated with longer hospitalisation recovery time, and relative to non-spontaneous birth, it's much worse, but relative to an emergency section, it's better. The hospital days are relatively cheap after an emergency to caesarean section because basically the woman's generally quite well and doesn't cost you too much in terms of finance. Again, do we get specific here? In Kate's case, I understand, because I have been reading the real literature, it's Woman's Day, that she's going to recuperate her parents' $7 million country estate at Bucklebury Manor. So I guess the district midwives are just calling in there. And of course, delayed in returning to driving is not so significant if you've got a chauffeur. So then we have to ask ourselves, do people really understand any of this crap? I think probably not. If you're going to get a housing loan in Australia, the law says you actually have to go to a lawyer and have him explain your housing loan mortgage, which means that he's going to tell you that you're borrowing money from the bank, you'll have to pay it back over a period of time, and you have to pay for the privilege with a thing called interest, which is going to cost you a bit more. And if you need that explained by a third party who requires a formal appointment of fee and a signature, how will you ever understand the relative risks and advantages we've just discussed here? New South Wales Health comes to the rescue again and gives us advice that we should use things like allowing the patient plenty of time to think about things. That's what we parents say, we'll see. And you then offer the opportunity to a second opinion, which is when I tell them to ask their mother. So at the end of the day, we get to our situation, the die is cast, and we make a decision as to what we're going to do. So what's the answer for the Duchess? She's a pregnant woman, she's going to deliver on that basis. The aforementioned details should be in our heads. She's a special case. With a couple of specifics I think I'm going to put to you now will actually swing the argument well and truly in my favour. We're going to get a bit personal here, but I hope you'll bear with me. That was my phone. There's the Medusa factor. Once, good idea. Once she married Will, she became royal in body, mind and soul. And that's quite a significant change to a human being. And her whole body is included in that transformation to become a royal. And to put it simply, her perineum has now achieved royal status. Now, a vaginal is quite problematic because this would entail commoners gazing upon that royal perineum. And I'm not sure, but I believe that this has the potential for turning those commoners into stone. The Medusa. One option to solve this would be that the lead obstetrician should be made a lord, fuel to the fire about the medicos with the god aspirations, and all the attending midwives would have to be ladies, and that's quite problematic too. Alternatively, the practitioners would need to avert their eyes throughout the whole process, which means vaginal examinations would see professionals pouring around in the dark trying to feel what that doesn't look at all. And they would have their hands poised but not touching because they didn't want to be involved in that moment of delivery. We wouldn't even know the little one had been born until good old Will cried out, you know, I say chaps and lassies, look there now. Have a look, it's up. Oh, no, you can't look because of course you turned to stone. So you can't have it. And any repair work, which is quite problematic, would need the Perseus technique, he's the guy who took the deal out here, where we'd have to use a mirror to help us repair the perineum. That could be quite problematic. We'll end up sewing up the wrong hole, I imagine. The royal lower abdomen presents no problem. There's also the genetic issue. And without getting too personal, there is a strong family history of very big sticky 80 years. And without going into the actual mode of inheritance, I'm pretty certain that this baby's going to be in trouble. And let's just say if the child doesn't inherit those ears, there's going to be a few questions asked about paternity. Family history. And we don't want that sort of scandal in the royal family again. So I think that although I admit oral dystocia is not a well-recognised syndrome in the textbooks, I think it could cause obstructed labour in this scenario, and I'm pretty sure we're going to be in trouble. So I think that's the final nail in the coffin for me, and I think that the elective caesarean section is definitely the way to go. I thank you for your time. I'd also like to point out my third reference. I did check the Bible on the way through.
Thank you, Peter. Well, that didn't disappoint in the slightest. I might at the very end we'll get both Peter and Sally, if they're still talking, to stand together and just answer any questions or have a discussion. Our second speaker, Sally Tracy, I've had the enormous privilege of working alongside for about 5.5 years, I think it's been now, at the Royal, both in an academic sense and also in a clinical sense, and certainly in sort of a administrative and organisational sense. And Sally has most recently just successfully first authored a publication for the Lancet, which is one of those things that there aren't very many midwives in Australia or anywhere managed to do, so she's academically been very, very successful. Sally's professor at the University of Sydney, conjoint professor here at UNSW, has over 30 years. It's over 30. So
Not over 31.
very close. Experience as a midwife. She's worked in Australia, New Zealand and the UK, so she certainly has worked in England, so she has deep insight into the royal family and how they function. And she has a broad research interest, mostly at the moment focusing on caseload midwifery and the midwife's role in maternity care. So I'm sure Sally won't disappoint in equally stimulating us. Sally.
Thank you, Alec. And Peter, how tragic to be an obstetrician. I'm terribly sympathetic towards you, of course, because we've seen how the trials and tribulations, the sort of weighing and the sort of toing and froing and the terrible tangles you get into when you start talking about elective caesarean section. The one thing that has escaped you is that the royal family have a tradition and have a custom that is centuries old. We don't need to go there. So I begin my talk with the swan. Last week I had the opportunity to visit a very modern president of the Royal College of Midwives in Oxford. And after we took tea and homemade oatmeal cakes, she said, would I like to come and see the Queen's Swan? Which I thought was quite extraordinary, really. Anyway, we potted down to the bottom of her garden in Oxford, and at the bottom of the garden is a tributary to the Thames. And if we were ever in doubt that there is tradition and custom and that these are very strongly held, and I can't find my thing to push it forward. Is it this one? Oh, do I have to use that? Oh, go on. Show me how to. Which one? Yeah. So if we were ever in doubt, at this moment, the Queen's Swan Warden is upping the swans on the Thames, and this has been something that has been done since 1126. When the brood of cygnets pop up, the fellow in red there calls cygnets up, or up swan, and when they pass Windsor Castle, their oars all go up, and they salute Her Majesty the Queen, Seigneur of the Swans. I just think this is stunning, that so much tradition and history and custom continues to this day in this format. I mean, not embarrassed about doing this. It's just the way it is. So when we come to the royal birth, we don't need to go through these tangles, if you like, of evidence-based medicine, of what's right and what's wrong and how's the perineum going to go. There's no question. The royals give birth at home. Full stop. They have done since Egbert or Ethelbert or whoever it was in 802. But I want to walk you through, we won't just settle with that, we'll walk through a few of them and show you that this is in fact what happens with royal births. Let's start with Her Majesty Queen Elizabeth II. She gave birth to her 4 babies at home, Prince Charles in the palace, Princess Anne at Clarence House, and then the other 2 boys at the palace. This was in the Times talking about the dilemma that the Queen had, because she had to actually go downstairs to give birth in the Belgian suite. And this was because the midwife's knees were so creaky. Poor old Sister Rowe was so ancient by this time that actually she couldn't go up the stairs, so the Queen had to come down. Never mind, 4 babes, mother and father, all healthy and strong, and as we know, as we're going today. Now, Princess Elizabeth is quite an enigma. She was born, of course, at home in her grandfather's London house in Mayfair, which is no longer standing, actually. The royal, the press that came out after her birth said that previous to the confinement, a consultation took place, and a certain line of treatment, which was, we understand, code for caesarean section, was successfully adopted. Now this means that Princess Elizabeth was born in Mayfair in 1926 by caesarean section at home. So we don't even have to go for our caesarean sections to hospital. Even our caesarean sections are performed at home. I actually find it difficult to believe that in 1926 a caesarean section was performed. However, I've been in touch with the Wellcome Library and everybody's on the case, and no, it appears that Princess Elizabeth was born by caesarean section at home. I'm going to jump a few of the royal families because they're sort of moderately boring. They had 8 or 9 children at home, and we get to Queen Victoria and she had 9 children at home as well. But she's rather interesting because she's probably one of the only sources that we have, primary sources, because she kept so many diaries. We actually know what she felt about birth and how she gave birth and some of the interesting things that happened around her time. When she gave birth to her first daughter, Victoria, there was an editorial in the Lancet, and the editor was quite hostile really, because Queen Victoria absolutely detested being pregnant. She thought it was just the worst thing that anybody could do. Nevertheless, she had 9 children, but she did hate it. And she particularly found breastfeeding disgusting. She thought that was for cows and dogs. And she said so in her letters. So the editorial to the Lancet said, it has long been the fashion in the higher circles for ladies to commit to the nurture of their infants to others, custom which in the majority of instances would be more honoured in the breach than in the observance. I have heard with regret that our sovereign, in accordance with regal custom, is about to elect a wet nurse for the expected scion of royalty, and goes on to castigate the Queen for having chosen not to breastfeed. She wasn't swayed, and she chose one of 6 wet nurses and went on to have them feed her babies. The other really interesting thing about Queen Victoria was that she was the first recorded royal in history to have used anaesthesia. And so of course we come to James Young Simpson, and here we've got a picture of him having a chloroform party with his mates. And this is the sort of thing they did, and then woke up in various degrees of consciousness. He also experimented on himself, and of course here's his butler finding him sort of unconscious on the floor. He talks about administering the drug in a little of the liquid diffused upon the interior of a hollow-shaped sponge or a pocket handkerchief or a piece of linen, and putting it close to 1 inch from your face and then moving it right up to your nostril. And of course this is what happened. He administered, the first report of his administering chloroform, Mrs. Carstairs, who was so grateful she named her baby girl Anaesthesia. I haven't seen any girls called epidural wandering around the world. It's time yet. There is time. He reported 3 weeks later that, chloroform was absolutely the way to go, that every principle of true humanity, as well as by every principle of true religion, it should be used, and was so taken by it that when he was made a baronet in 1866, the inscription on his coat of arms was Victo Dolore, pain conquered. Nevertheless, Prince Albert was, in fact, had quite a scientific mind, actually, and he was well informed about anaesthesia. In April 1853, he summoned the leading English practitioner for an interview at Buckingham Palace. Now this is John Snow of the epidemiology Lambeth pump handle fame, who was, of course, also very important for his use of chloroform. The Church of England and Sir James Clark, the Queen's senior physician, were unsure about this. They didn't think the Queen should use a drug that common women had used. But nevertheless, in 1853, John Snow administered chloroform at the birth of Prince Leopold. And a note in his diary records the inhalation lasted 53 minutes, the chloroform was given on a handkerchief in 15 minimum doses, and the Queen expressed herself as greatly relieved by the administration. However, Snow was not content with the handkerchief and the drops of chloroform, so he went on to invent this gadget. And I won't bore you, anyone who's interested, I've actually got a full description of this gadget and how it works, which we can talk about over supper. But basically, it was supposed to be an improvement on the handkerchief. However, for the birth of Beatrice, before Snow arrived, Albert had given his queen the first dose of chloroform on a handkerchief, and Dr. Snow was not amused. Her Majesty is a model patient, he declared, and of course he was fortunate that there were no complications, because, in fact, as you'll see later on, that actually had very bad consequences. But there was a Christian backlash, and we heard about this from Peter's talk, of course. Strong opposition from the doctors and clergy who quoted the book of Genesis, and the quotation from the clergyman's letter as a fair sample shows the spirit of the time. He said, "Anesthesia is a decoy of Satan, apparently offering itself to bless woman, but in the end it will harden society and rob God of the deepest cries which arise in time of trouble for help." Now, I thought this was rather interesting, because this was also reported in the Lancet of 1828, Blundell's gravitator. You know, people were full of making gadgets in these days, but this one's a beauty. This is for a blood transfusion where you hook the physician to the patient and just let rip. I don't know, there probably are sort of reports of how that worked and what happened. But on a more somber note, we look at the death of the Princess Charlotte, who after a 50-hour labour, her baby and she died about 3 hours later. And of course the poor unfortunate obstetrician, Sir Richard Croft, was criticised roundly because he hadn't used the forceps, which of course had become very fashionable in those days in England. And it's not known whether in fact they would have made any difference. And for anyone who's interested in this, I did find a very good full account of the post-mortem of Princess Charlotte, which is very interesting reading for anyone who's interested. That was in the Lancet, and it was the letter from Dr. Sims to Dr. Clark. Dr. Sims was actually the physician who was kept outside the door, and he, in a letter, wrote and talked about what happened, what he felt had happened in his birth. It seems that she possibly died of postpartum hemorrhage, although she didn't lose much blood. Of course, in those days, these young women were bled for every possible malady. And so she may have had an extremely low hemoglobin, poor thing, by the time she gave birth. Now, all the kings and queens in England, there it is, King Egbert it was, born in 1802, so King Alfred the Great, Queen Mary, all and sundry, every queen and king in England, born at home. A castle home, nevertheless, but home. Which brings me to why there is a little dilemma with the Duchess, because they only have a cottage. And so not having a palace at this point means that there is a possibility she'll go to St Mary's. So I'd like to just talk about some of the things that protect birth that we've actually left behind in all of our dilemmas about whether we should have elective caesareans or not. You may have heard in the news that Kate her last public duty was performed last week, where she launched the Royal Princess, which is a big ship. And true to form, a month before she's due to give birth, she will enter into a lying-in period. This has traditionally happened through the centuries, for many, many centuries. Women in the advanced stages of pregnancy have a lying-in time where they remove themselves from the world, and in these years when this was actually depicted, the windows and doors were kept shut because, of course, the drafts were considered to be bad spirits and cause illness. visitors came, the midwife came, women did things together really, and in lots of ways this would have been also a goodbye for the friends of the women giving birth, because of course so many women did die in childbirth. But as you can see here, the woman is surrounded by the company of women, and there isn't sadly a man or an obstetrician in sight. This is very interesting because we actually have a first-hand account of the sort of linen and the trappings of the birth room. This was in fact painted in 1400, but it describes the birth room of the first Earl of Norfolk, who was born in 1300. The walls and ceiling were close hung with precious tapestry woven with gold and silver threads, and the floor thickly laid with rich carpets. The tapestries were left loose at the single window so the Queen could order a little light and air, though this was generally felt inadvisable. Precautions were taken too about the design of the hangings. They were always geometric shapes, not animals, not birds, because this could have given the Queen's mind some fantasies, and so therefore the child might be deformed or born with an illness. The posset. The posset's a very interesting thing. This was an alcoholic drink related to the eggnog, still known and still made. The posset pot we don't see so often now because we have plastic straws, but it was held on both sides and the spout worked as a straw. We do have a recipe for posset, which was milk and wine, and so you can see from the recipe that the thing it turned into a sort of curdy sort of thing, which makes me realise that the posset still has meaning today. Anyone who's burped a baby, it's left a nice little curdy sick on their shoulder or lap, will understand that the word posset, anyway, is still alive and kicking today. This is not to be confused with caudle. The caudle was a warm, spiced wine shared between the mother and the midwives and the women in attendance, and caused, actually, this was probably the root of the historical notoriety, I guess, of the midwife who was always drunk. Because I guess, you know, once they'd actually sort of been at these births and been locked up for 40 days beforehand, the caudle probably sort of was a little bit, you know, it was a bit over the top. In the 1800s, the doctors who were starting to enter the birth room actually thought this was perhaps not a good idea, that it could make new mothers vulnerable to infection. And interestingly, at Queen Victoria's first birth, of Victoria, there was a caudle cup, but by 1857, the custom had been abandoned. I haven't really touched much on the neonates, but this comes from a book written by Francois Morisot in the 17th century. And he talks about the resuscitation of the newborn. Lay him speedily in a warm bed, carry him to the fire, then let the midwife sup some wine, clearly from the caudle cup, spout it into his mouth, repeating it often, let the face be uncovered that he may draw breath the easier, and let the midwife keep his mouth a little open and cleanse the nostrils. And actually at a later date, in another revision of this book, you put an onion up one nostril of the neonate. He didn't agree with the usual practice, which was to plop the wet, quite heavy placenta on the chest of the baby. Now, gossips. Gossip is a beauty. The English word gossip, or god-sibling or godparent, originally signified the female friends and relatives invited to help the woman in labour. So childbirth was a mysterious event because of the fact that men were unable to enter the birth space and therefore couldn't accurately document its happenings. It's perhaps because of this exclusive female world that gossip became synonymous with idle or malicious talk. Men could only imagine what women talked about, and together they imagined the worst. It is the exclusivity and the mystery of women's friendships and birthing communities in the early modern period which led to an association of women and gossip. So, I'm moving on now to the beautiful plates that provided the food and nourishment for the mother, and the plate, of course, itself would offer inspiration and succour to the mother who'd given birth. This plate was made in 1600. And on the plate was a typically Renaissance comfort food, which was a mixture of chicken and milk and cream, and it was served on these plates with sugar. This one here shows the birth of Heracles. This is a very famous plate. It was made in the 15th century, and I think it lives in a museum in Florence. In one story, of course, the thing about these plates was that they had to have they provided inspiration for the mother as well. In this story, the clever midwife got the baby out by playing a trick on the goddess of childbirth, who was holding up the delivery, and that was the birth of Heracles. Now, one of the other very interesting and very necessary additions to the birth room in these early days was the astrolabe. And this was a multifunctional instrument used to tell the time, to determine the length of day and night, and to simulate the movements of the heavenly bodies for surveying and for astrological purposes. If you look here, you can see the fellows at the back of this woodcut pointing to the stars in the sky at the same time the woman is giving birth. This was very significant because astrology was extremely important to the Elizabethans. It was widely believed that the planets and the signs of the zodiac exercised a profound influence over human affairs, and that men's fates and natures were governed by the stars, so that many prominent Elizabethans were in the habit of consulting their favourite astrologer before taking any decision. And you can see here, John Dee was the court astrologer to Elizabeth I, and this is in fact her horoscope. She was born at 2:26 p.m. on September the 7th, 1533. Another addition to the birth room was the birthing chair, which we actually have one at the Royals, we're very excited about, but these are clearly ancient things that have been sort of sidelined, I guess, with the modern bed and with the elective caesarean section and what have you. These ones were, in most of the pictures that you see of the women giving birth, they're all seated on the birth stool, they're all upright, midwife at the front of them there, and the women in attendance holding her up the back. You see the same through all of these centuries, the same sort of thing, this upright position, midwife in front, the women behind helping the woman. And again, this one was in 1559. Now here is very interesting. Here's 1887, and who have we got in front of the woman at this point? A gentleman. And it wasn't very long after this time that instruments were brought into the birth room. And you can see here that the woman is almost